Okay, thank you very much. Welcome everybody. Really good to have you with us here. I think Michael told me a few minutes ago about just after 5:30 in the morning, tomorrow morning, over with him in Australia. So we're really very, very grateful for him getting up so early. Maybe he normally gets up at this time. I don't think so. To join us for this webinar. So I'm Vice Chair of the Faculty of Clinical Informatics at the moment. I'm a GP as well, and I have a role as clinical lead for primary care in NHS Wales Informatics Service, which does primary care IT for in Wales. And like everybody, you know, it's really interesting to have these kind of like a bit of like a retrospective around the impacts of COVID. And it's something that no matter where we are all around the world, we're all able to like tap into it and understand that we know what's happened with us. And how has it been in a different part of the world? And we've all had different kind of COVIDs. Our rates and everything have been much higher in the UK than in Australia, but it's the same kind of challenges that have come up. The same, I'm expecting some of the same kind of changes possibly have happened, and particularly Michael is going to talk as well about the uses of data, and we've had the same, you know, in the UK, and I'm sure that'll come out whenever we get to our discussion. And how lucky are we to have Michael actually joining us? Michael is a GP as well, and is Deputy Chief Medical Officer in Australia, and an AM, and done lots of different research and worked in digital health. And Trish Greenhalgh today, she tweeted this evening, she's very sorry not to be able, another one of our founding fellows, not to be able to join this evening and join in to hear what Michael was going to say, which was going to send you a paper. So just in case you missed that, look out for that too. And she's been doing an awful lot of work on impacts of digital health on primary care during COVID as well. So we're going to have quite an informal kind of feel about this tonight. Michael is going to talk without any slides and just give us a rundown of what's been going on there, and that'll be about 20, 25, 30 minutes, we'll see, and then we're going to come in with questions. So feel free to start leaving questions or any reactions in the chat down the side. I'll keep an eye on it, and maybe when we get to the end, I'll pick out some of the questions, or if you feel like there's something else you want to ask, raise your hand and we'll go to your question. So thank you again very much, Michael. Looking forward to hearing from you.
So thank you, Anne-Marie, and good morning to everybody. And it's wonderful to see a number of dear friends who I've known for a long time, rather than old, on the call as well. So thank you for the invitation to join you. As you said, it's just gone 6 a.m. Tomorrow in Canberra. I'm in the bush capital at the moment, where the Australian government is based. So I was asked to talk about the impact that COVID-19 has had on digital health, particularly in Australian primary care. And like a good clinical informatician, I thought I'd tackle this from looking at some of the clinical challenges that we've had in Australia during the pandemic, and then look at how digital solutions have been helping us. So the digital tools which we've been using to help us at this time. But in preparing for this talk, I was thinking back to just over a year ago, when of course all our lives began to be disrupted by the arrival of the coronavirus in our respective countries, and the beginning of the pandemic, and reflecting on how much has changed over the last year. Things that we previously have been, many of us on this call have been wanting to see happen for quite some time, all of a sudden are really quite ubiquitous. And I think that this technology that we're using to speak together today is a great example. The ability for us to be using these video connections to speak with each other. And this week I'm giving talks at international conferences in Yemen and in Turkey and in Canada, all without leaving this room, and it's quite a change over the last year. The other thing I wanted to say was a huge thank you to everybody on the call, because I know that through the Faculty of Clinical Informatics, you've been very much a very strong advocate for the appropriate use of this technology to support the people of the United Kingdom during this unprecedented medical emergency. And I also want to say that I hope that we do get to have some quite rigorous discussion, because I'm very keen to learn from you about the experiences and challenges that you've been having, because I think it is really important that we start to share our experiences of digital health utilisation, particularly in primary care, with the rest of the world, so that we can work out what has happened in different countries over the last year, what's worked well, what hasn't worked well, and then that will help us to frame what happens going forward in our respective countries. So the Australian experience of the pandemic, clearly we were watching with alarm last January as this new coronavirus started to appear in the reports from China, from Wuhan. We then saw how rapidly it was spreading through China, then into other parts of Asia, particularly South Korea. And then all of a sudden it appeared in Iran, and then it appeared in Italy, and just seemed to overwhelm the healthcare system in Italy overnight. In Australia, being an island like the islands of the UK, we were able to start to close our borders. Initially, we closed our borders to tourists coming from Wuhan region, and then from all of China, and then all of a sudden a succession of different countries. And then at the beginning of March, the decision was made to close the international borders. And the only people allowed to come into Australia from that time were Australians returning from abroad, and of course the people on planes or ships who were involved in import and export of essential goods. At the same time, at the beginning of March, we introduced the requirement for mandatory supervised hotel quarantine for everybody coming into the country, and that has been a very effective way of preventing outbreaks, in many cases, of community transmission of COVID-19. We've to date had 29,000 confirmed cases of COVID-19 in Australia, many of those in returned travellers, all of whom have gone through that 2 weeks of mandatory quarantine. We've experienced 909 deaths from COVID-19 throughout the pandemic, and we've had 2 waves. The first wave was in March and April, like much of the rest of the world, and this was obviously introduced before the stringent lockdowns of the border was in place, and it spread right across the country, mainly spread by the return to Australia from passengers who had been on cruise ships. And I'm not sure that the cruise ship industry will ever recover in our part of the world as a consequence of the terrible media that they had, and the number of people who'd been passengers on cruise ships who subsequently died. And then we moved to a period of after a national lockdown, we moved to a period of having very few cases in the country, and then we had a second wave focused on the city of Melbourne. And there was a breach from one of the quarantine hotels involving some of the security guards who went home, infected the people that they were sharing their homes with, who also happened to be working as personal attendants in aged care facilities, as cleaners in hospitals, as workers in abattoirs, in meat works, as Uber drivers, a whole range of other areas where the virus was able to escape and get into the wider community. And the second wave in Melbourne actually resulted in far more cases and far more deaths than the first wave, which was nationwide. And very sadly, the majority of the deaths occurred in residents of what we call residential aged care facilities, nursing homes, long-term care facilities, whatever term you use, which has been part of the tragedy of COVID-19 in our country. But from the primary care perspective, I've been working in Canada, as some of you know, over the preceding 3 to 4 years. Returned back to Australia just before the borders were closing. I'd been asked to come back by the Chief Medical Officer of Australia to provide support during the pandemic, the sort of request that you really can't say no to. And so I returned to Australia, and I was immediately asked, we need a plan for our primary care response to the pandemic. Can you do it? And by the way, the Minister needs it tomorrow lunchtime. So I sat down with some colleagues in the Department of Health, and we drafted out the pandemic response for primary care. And it was very fortunate that I'd been living in Toronto for the preceding 3 years, because in Toronto, Toronto is one of the cities in the world which experienced deaths among healthcare workers during the previous SARS pandemic of 2002-2003. And the shadow of SARS was very long on Toronto, and there had been a number of inquiries after the end of that SARS pandemic, looking particularly at the deaths which had occurred among healthcare workers. And there had been 3 deaths in Toronto during SARS among healthcare workers, one in a hospital nurse, one in a community nurse, and one in a GP. And as a consequence of the investigations and the Royal Commission and the inquiries into the SARS pandemic, a number of changes have been made in Toronto and right across Canada. Every hospital that's been built in Canada since 2003 has been built to be able to be converted overnight into a fever hospital with single rooms, with the negative pressure, with a real focus on ventilation and airflow in order to protect the staff, with full PPE readily available in very high numbers for the staff, and actually with robots delivering medications and meals to the patient rooms to reduce the human interaction if and when another pandemic occurred. The other thing which really struck me when I arrived in Canada on my first day working in family practice, I was fit tested for an N95 respirator mask, and then was given a card to carry in my wallet so that when we had an outbreak of a serious infectious disease, we would already know which N95 mask was appropriate for me. And then 3 years later, when the first reports of COVID-19 started coming out of China, we were all recalled. We had a second fit test to make sure we were still appropriate for the same size of mask and hadn't got fatter or thinner or grown a beard or shaved one off. And that was totally different to what happens in Australia. So Canada, of course, was therefore a little bit better prepared than other countries. And it's interesting because the other countries which experienced the SARS pandemic, China, Hong Kong, Singapore, Vancouver had cases as well in Canada, as well as Toronto, all seem to be a little bit better prepared for this pandemic than many other countries. But I guess we will all have our inquiries once the dust settles on COVID-19, and we'll be looking at ways that we transform our healthcare systems. So back to the primary care preparedness, and based on the experience in Canada, we came up with 5 principles for tackling COVID-19 and preparing primary care in Australia. And there were digital health elements to each of the principles, which is what I want to talk about. So the first principle which we had was the need to protect people who are most vulnerable to COVID-19. And in Australia, we were in the fortunate position of being able to watch what had happened as the pandemic had hit a number of other countries, China, South Korea, Iran, Italy, and then into other parts of Europe. And so we knew very early on that the people who were most at risk were older people, especially people aged over the age of 70, people with certain chronic health conditions. It's taken a while to build up a list of what they are, but initially it was clear that smokers with respiratory and cardiovascular disease were at increased risk, people with diabetes were at increased risk, people with significant obesity were at increased risk, people who are immune compromised, including people with blood cancers and people on immunosuppressants were at increased risk, and a number of other people. And what do we know in countries like the UK and Australia? We know that all those people are people who receive their health care largely from general practice, from primary care. And the people who were going to be providing care to those people if they did become infected with COVID-19, for many of those people was going to be general practitioners, community nurses, and others. Because what we also knew from the early experience was that only about 15% of people diagnosed with COVID-19 were being admitted to hospital with serious or severe or life-threatening disease. The majority of people, 85%, had mild to moderate symptoms, if any symptoms at all, and were being cared for through primary care. We also knew from the very early experience, and particularly from what happened in Italy, that the residents of nursing homes were at particular risk because of the congregate living arrangements which occur there, and because, of course, many of these people are very elderly, frail, and, of course, often have comorbid conditions, and that we needed to be doing all we could to protect those people. Now, again, the people providing the healthcare to the residents of nursing homes, in Australia at least, are general practitioners. Every resident of a nursing home in Australia has their own designated GP who visits quite regularly, usually visits a number of people in the nursing home, and so would be provided, working with the staff of the nursing home to protect those people and to care for them if they became unwell, but were not so unwell that they needed admission to hospital. So very early on, as part of protecting vulnerable people, the Australian government approved the use of government-funded telehealth in consultations with all those people in those categories of being vulnerable. And this was new in Australia. We've had telehealth, of course, for more than 2 decades, being used particularly in rural areas. Telepsychiatry has become quite common to deliver services to people in rural Australia. But the Australian government, to that point, had not provided funding through our national insurance scheme, Medicare, for GPs anywhere in Australia to use telehealth to be able to provide consultations to our patients, but allowed it for vulnerable people at the beginning of the pandemic. We also recognised that one of the populations which was most at risk in Australia was our Aboriginal and Torres Strait Islander people, our Indigenous populations, and we were very concerned about the risk of COVID-19 getting into remote Aboriginal communities or remote communities in the Torres Strait Islands to the north of Australia. There was the potential that if COVID-19 took hold in some of those communities, that it could devastate, if not wipe out, communities, nations of people who have been living in Australia for many tens of thousands of years. This was a very serious risk to our Indigenous population. And, you know, sadly in Australia, many of our Indigenous people have serious comorbid health conditions, and so we're very concerned about how we're going to protect those remote communities. And so funding was provided to the remote communities to determine what they need to spend that money on to protect their own people. Many remote communities closed their borders to people from outside. They said to their own people, come into country and be here during the pandemic, do not leave, and we're closing the borders to people from outside. But here again, digital technology came into play. We rolled out point-of-care testing for COVID-19 into remote communities. We provided through the aerial health service, the Royal Flying Doctor Service, these point-of-care testing kits to allow the testing to take place. The Royal Flying Doctor Service was set up to provide emergency retrievals if people were infected with COVID-19 and needed to be evacuated out. Obviously, many remote communities are a long way away from the major capital cities in Australia and the ability for people to get healthcare. So again, point-of-care testing, something which has been, we've had a lot of pushback in Australia from the pathology lobby who don't want GPs doing point-of-care testing on grounds of quality, but really on grounds of protecting turf, I think. We just rolled this out and it's used by the GPs serving these communities and the wonderful community nurses working in remote areas and is again transforming healthcare delivery in those areas too. The second important principle, number one, protect the vulnerable. Number two was the need to segment people presenting to general practice or other healthcare settings from those presenting with respiratory symptoms that could be COVID-19, from those presenting with other conditions. What we know from past pandemics is waiting rooms can be an area where you can get very serious spread of COVID-19 and often spread to people who are already unwell with either acute or chronic healthcare conditions. So the Australian government worked with general practitioners in Australia to set up a network of general practitioner-led respiratory clinics, often set up adjacent to existing general practices, usually in demountable buildings which were brought in and put on site. But it separated the patients from those with respiratory symptoms needing to be assessed and then, if necessary, tested for COVID-19 from those people who are needing to see their GPs and practice nurses for other reasons. And some of this was done through drive-through facilities with people remaining in their car if necessary, but if people needed to be properly assessed, being able to take people into segmented assessment and treatment areas. Australian government funded 150 of these general practice-led respiratory clinics distributed right across the country. In Australia, we have a network of primary health networks, which are primary healthcare organisations. They worked with the government to determine where in their local geographic area we should site those clinics, and they were evenly distributed between urban areas and rural areas right across Australia within an hour's drive from 99% of postcodes in Australia. So we wanted to make sure that they're accessible to the population. And again, technology had its role to play here as well. We had a special software which was added to the electronic medical records for documenting what was being seen with patients coming in for assessment and for COVID-19 testing. That all then came centrally into the Department of Health, so we knew in real time how many people were attending these clinics, what respiratory symptoms they were diagnosed with, whether they'd had a COVID-19 test, and then able to follow up as to whether the COVID-19 tests were positive or not. And again, this was really exciting from a digital health perspective, because this was big data in healthcare being put into action to help us to address a very serious health emergency. And you know, I'm looking at all the different sources of data which we've been able to gather during the pandemic. As the Deputy Chief Medical Officer of Australia, I'm based in the National Incident Room at the Department of Health in Canberra, which is only opened up when we have an emergency. It had already been activated ahead of the pandemic to address the devastating bushfires which we had in Australia in the 4 to 5 months before the pandemic hit. It was also used during the White Island volcano disaster. I don't know if this hit the media in the UK, but at the end of 2019, a volcano erupted off the coast of New Zealand. There were a number of Australians from cruise ships who were on the island visiting the volcanic areas at the time, and very sadly, a number of those tourists were instantly killed during the eruption, and a number subsequently died of absolutely horrific burns after they'd been evacuated from the island. So again, the incident room was set up as we were returning those injured people back to Australia for treatment or repatriating their bodies home. And then the incident room again came into its own throughout the pandemic, and of course it hasn't closed yet, and will likely not be closing for quite some time. So they're the first two principles. The third principle was about the importance of continuity of care during a pandemic. And what we know from past experiences of pandemics is that often more people die from not receiving regular health care than die from the infectious agent. And this is because often regular health care collapses during epidemics or pandemics. And of course, we saw this happen in West Africa with the Ebola crisis a few years ago, where I know some of you were involved. And so we had the need to ensure that regular healthcare services were available to our population for managing acute healthcare conditions, managing chronic healthcare conditions, mental health concerns, and very importantly, keeping our preventive health interventions going, so that we didn't get a long tail of preventable morbidity and mortality occurring after the pandemic. So we want to make sure our childhood immunisation programs were running, our annual influenza vaccine program, our cancer screening programs for colorectal cancer, cervical cancer, breast cancer, and others. And so 10 days after we introduced telehealth for vulnerable people, the Australian government accepted a recommendation to roll out telehealth to everybody in the entire community. And this came in as the lockdown was rolling out across the country. And what this meant was that people were able to connect from isolation with their chosen GP and other healthcare providers and continue to have consultations. We did set up a caveat there, though, that if a face-to-face consultation was required, that would be available. And so GPs, if they had closed their own practice because they themselves were vulnerable people, they had to at least have arrangements where a patient who needed a face-to-face consultation could get one. I'm not sure what happened during lockdowns in the UK, but during lockdowns in Australia, you're allowed to leave home for 4 reasons. And one of those reasons was to seek medical care and attention. So visiting your GP or going to the pharmacy to pick up essential medicines was one of the reasons that you're allowed to be out of your home. And again, digital health came into play because Fortunately, in Australia, we have electronic health records or electronic medical records available in all of our general practices. GPs were able to access their records even if they were consulting from isolation in their own home. We have the ability for digital prescriptions, which was under development at the time, which was rapidly rolled out during the initial phases of the pandemic, and a lot of satisfaction amongst the population to be able to use telehealth to link with their chosen GPs and other healthcare providers. Interestingly, most of the consultations by telehealth were by telephone, because many practices had not yet set up the ability to do video consultations with their patients. We're learning about the challenges of delivering telehealth wide scale using the telephone rather than video consultations. We know that people often having consultations with their GP on the phone multi-skill and do other things at the same time rather than paying full attention. Whereas if you're doing a video consultation, it's very hard to multi-skill while your GP is eyeballing you and seeing what you're doing. And of course, as GPs, we know the value of actually being able to see someone in their own habitat, in their own home, in order to understand how that individual patient is able to cope with the healthcare concerns that they have. The fourth principle was around protection of the primary healthcare workforce and our primary care services. And so the Australian government started to roll out personal protective equipment, not just to doctors working in hospitals or in emergency departments, but to people working in general practice, community nurses, pharmacists, allied health professionals working in the community. And although we had very serious shortages of personal protective equipment early in the pandemic, as people did right across the world, with global shortages, and who knew that the majority of surgical masks in the world are manufactured in Wuhan province, but that's where they are being manufactured. In Australia, we started onshore manufacture of masks, of hand sanitizer, of a number of products. I think we revealed the perils of globalization and thinking that you can just import everything that you need from other countries, and so we've got a lot more onshore manufacturing occurring now than we had a year ago. But rolling out the PPE has allowed us to provide protection to our healthcare workers. We have not had any healthcare workers who have died from COVID-19 in Australia. To date, we have had one personal care worker tragically who died, someone delivering care to elderly people in their own homes. But again, the digital health answers came in here as well, in that, again, using big data, we're able to document the distribution of personal protective equipment to general practices and other community health settings right across Australia. And the distribution took place through our primary health networks, our local primary health care organisations, who sent through the data to the National Incident Room so we could document where there were shortages in the country and get shipments to those areas to ensure that we're protecting the healthcare workforce, the people who are putting their own lives and their family lives on the line to deliver healthcare during the pandemic. The fifth and final principle was recognising the need to support the mental health and well-being of our population. Again, the experience of past pandemics has shown us that the impact on mental health leaves a very long tail, and we expect that there are going to be mental health consequences from this pandemic for years after this pandemic ends. The level of tragedy and loss and the impact of isolation, the impact of separation from loved ones, the impact of closing our borders in a country with many people with family members in other parts of the world, the inability to come together to celebrate births and weddings and birthdays and the loss of loved ones. has a profound impact on people's mental health and well-being. And of course, the pandemic has also had a very profound impact on the mental health of healthcare workers. And the Australian government has provided very substantial additional funding to the organisations which provide telephone counselling and online services for delivering mental health to the population, as well as of course, the ability for people to use telehealth for mental health consultations with their GP, with psychiatrists, with psychologists, and with others. So I hope through those 5 principles I've been able to demonstrate some of the ways in which clinical informatics has actually been embedded in the primary care response. Of course, we're now moving to the next phase of the pandemic, which involves the rollout of the vaccines. And in Australia, we've been rolling out the Pfizer and AstraZeneca vaccines. We have limited doses of the Pfizer vaccines because they're being produced overseas and shipped to Australia when the country in which they're manufactured allows them to leave in order to go to other countries. We have been relying on offshore production of the AstraZeneca vaccine, but from this week we have onshore production of the AstraZeneca vaccine in Australia, and we have a facility here which is now rolling out 1 million doses per week, which will allow us to use the University of Oxford AstraZeneca vaccine to vaccinate the majority of the Australian population, but also to vaccinate the people in our near neighbour countries, New Zealand, the islands of the South Pacific, Papua New Guinea, which has a very serious COVID-19 crisis, really the first wave occurring right now, and a lot of aid is going into Papua New Guinea, Timor-Leste, Indonesia, which is the largest country with very serious COVID-19 challenges. We also, of course, the final thing I wanted to focus on was just the information which we're pushing out through the Department of Health. And we have our own website, health.gov.au, which has become the single source of truth on COVID-19 and the national responses in Australia. And again, using digital technology to push out health information to the population. And we know from past pandemics that one of the biggest challenges to public health delivery is inconsistent messaging and different messages coming from different levels of government, different healthcare service providers and so forth. So we focused very early on in Australia in having the Australian Government Department of Health being that single source of truth for the population, and people are able to go onto the website. There's a vaccine eligibility checker. You've probably got something similar where people can put in their details. They're asked a series of very quick questions. They're then told whether it's their turn to start making bookings in their general practice to get their COVID-19 vaccine. Then they can put in their postcode. They can find which practices in their local area are delivering the vaccines, and then they can go to that practice's website and do an online booking to get the vaccine. Again, the ubiquitous use of digital technology helping us in tackling the pandemic and helping us in ways that I think many of us would not have thought was going to be possible just 1 year ago. So, Anne-Marie, I'm going to stop there, but happy to field any questions we might have.
That's great. That's super. I'm really kind of fascinated just by, I mean, all the things that you've been talking about, quite similar to the things that we've been, going through as well. But in a way, I'm sort of, very sadly, our death toll and our numbers of cases, whatever, have just been so much higher, higher here in the UK. So, for example, I think you've had about just over 900 deaths in Australia, while we've had over 5,000 just in Wales with our population. So I think it's about 50 times the level of deaths that we've had in the UK than in Australia. So in a way, we've gone through all this, we were going through it all, and I feel that we're still very much, I think, kind of in the midst of it. We're still kind of coming down to the, the numbers of new cases. I think there was like still over 6,000 new cases in the UK in the last like day or so, and that's much lower than it had been before. But we're still kind of at that level. And while I was talking to, a relative that works in Sydney Opera House, and he was saying that, it came to the end of the summer season, they were still the first opera house to actually be opened again in the world, were operating with like full houses near the end, and that's just such a tremendous kind of achievement, of like a sign of sort of being back in a way to normality. Well, I guess our feeling is just that we're still in a way feeling quite far away from that. And I think that there's some question I'm going to ask. If Andrew's on, I'm going to ask Andrew, because he's got two things that he's kind of put in there, and I'm trying to work out a bit where Andrew is or has been, whatever he's mentioned about Scotland things. So I thought it would be, could you ask your questions there, Andrew? That would be really good. Thank you.
So, Michael, thank you. That was really fascinating.
Yeah.
I'm from Scotland, where we've had a sort of our own informatics response, so the others may not be with all the stuff we've been doing locally. But in general, across the UK, I think it's fairly accepted we haven't quite got the citizen healthcare participation records right. And so a lot of the challenges have been around communicating with people, rearranging appointments, avoiding those COVID harms, and also even just the vaccination, where we've just adopted the blue letters and we're writing out to people because it's just easier to do that. And the mass vaccination centres, I have to say, we've done 2 million doses of vaccine in Scotland really in quite a short time. So the mass vaccination centres do probably work better than the individual GP ones. But the challenge was, Tim Kelsey, you took my healthcare record and you were a bit ahead of the curve. You managed to get that through. Our stuff all collapsed. Tell us a bit about how attitudes were shifted. I visit Australia every year, got relatives there, so I've seen all the discussion going on and the kind of issues of consent and concern. Can you reflect on what that feels like to Australian citizens now, as they've been so controlled by the government recently? Because we're having a big kickback here, frankly.
Look, one of the things which has really surprised me is how accepting the Australian population has been of the public health measures which have been put in place. And I think one of the secrets was right at the start of the pandemic, our political leaders accepted that they needed to take the health advice and to follow the evidence being provided to them. And there's a few measures which I think have been really interesting. The first is that the Prime Minister established what's called a national cabinet, and he meets regularly with the premiers of each of the states and territories of Australia. We haven't had anything like this since wartime, where we've had all the political leaders coming together. Now, they come together virtually most of the time, of course. The only public servant who attends those meetings of the National Cabinet is the Chief Medical Officer. And I've been acting in that role a few times and have had the privilege of being there, providing the advice, the health advice, to the national leaders. And then they take that advice. The Chief Health Officers in each of the states and territories have been working hand in hand with their premiers on how to protect the population. And of course, the media is across all of this. And I think the population actually are incredibly grateful that they've got doctors and nurses and other public health officials who are helping to determine how to keep people safe.
So, Michael, I don't know if you picked up, but I think Andrew's question was very specific. Was it on this kind of like about patient-facing services, about people going and accessing their records? Has you, because yeah, I could see this discussion like a few years ago. It's actually, I hadn't been thinking about it, so well done for raising it, Andrew. Did you, as part of this, have a much bigger uptake of My Health Record, or has it just kind of like not really been a talked about thing?
Hardly spoken about.
Hardly spoken about.
But it's being spoken about now.
But it's been.
And the reason it's being spoken now is because of the vaccine. So we have legislation. Every vaccine has to be entered on the Australian Immunisation Register, another example of big data. And that way, as a GP, if someone comes to see me and they say, I've had a vaccine elsewhere, I can go onto the Australian Immunisation Register, see whether they've had the Pfizer vaccine or the AstraZeneca vaccine, and we can arrange their second dose. The information on the Australian Immunisation Register is downloaded onto your My Health record, and you can access that yourself. And you can also have that information downloaded onto the Medicare app on your smartphone, and you have a certificate on your smartphone saying that you've been fully vaccinated against COVID-19. So it's another ubiquitous way that we've had the technology sort of rolling out, and people just accepting it. I think it actually may lead to increased interest in My Health record now that people have something of tangible benefit. Also, their influenza vaccine will go in the same way. We've actually provided legislation which mandates every vaccine now has to go onto the immunisation record, linked now into My Health record.
Can I just as follow up to ask, how do you do the authentication, the checking out that somebody really is somebody in My Health record? Is that done? There's a service, the NHS login, where you have a little bit of video, you show some identity, and like a human works out that that's who you actually are. Do you use some kind of way of remotely verifying identity for My Health record as well?
So people, of course, have the right to say who gets access to their My Health record. If your GP has access, there's automatic downloads from your practice, which is set up when people register. People can access their own record through passwords.
But how do they verify their identity? How do you have to go into your GP practice to get them to verify your identity, or can you do it remotely?
Just do it remotely.
Okay, so it is something like interesting, because I think this is the thing, services that depend on humans to do that. If it becomes, oh, you better get signed up to be able to show that you've had COVID vaccine, your service could get overwhelmed very quickly. Yeah. Very busy. So I'm going to look down through some of the other questions that we've had sort of coming in. Mary has asked, maybe you want to come in, Mary Hawking, and ask about the digital inclusion affecting the Australian response to the pandemic, and is there any program to address it? This has been something very pertinent in the UK as well. So have you plans?
Yeah, no, thanks, Mary. That's a great question and really important. It was one of the reasons why, when we rolled out Telehealth, we fought very hard to allow the telephone rather than requiring video consults and people to have computers available, because we do recognise, of course, that many people do not have access to the technology, and so therefore you can use your telephone to talk to your GP as well.
Yes, but sorry, what proportion of the population in Australia doesn't actually have access to even a telephone?
So the majority of people have, sorry, Mary, yep.
I have a personal problem that my smartphone is a Galaxy 2. So it's not going to take an NHS app. And if we're going to have vaccine passports, I should probably either not have one or be forced to buy one of these enormous outsized modern smartphones. A dilemma. In the outback, if you don't have good phone mobile coverage, you don't have a landline. Mm-hmm. How far are you excluded from any of the benefits of telemedicine? And how does the Australian system cater for people who don't have even telephone communication?
Yep, so look, we recognise that many people don't have smartphones, certainly. Telephones are pretty ubiquitous everywhere across the country, even if it's satellite phones for people living on very remote communities. You don't need digital certificates. in order to prove your vaccination. Your GP can print a copy out for you to show that you've been vaccinated. You can carry that with you. Last winter, we required everyone going into an aged care facility to have proof of influenza vaccination. That was accepted just with a printout of the vaccine certificate. So you're 100% right, making sure that what we're offering does not require everybody to have a certain platform of technology has been incredibly important, because we know that doesn't happen. We are worried about some of the hidden populations in Australia, and of course it was the hidden populations where the second wave started to roll out amongst people who are new immigrants to Australia, didn't understand how the healthcare system works, people who are living in poverty, working with uncertain employment. We had a real challenge with people working in nursing homes who were working in multiple nursing homes as casual employees. If they didn't go to work, they didn't get paid. So if they had symptoms, the incentive was actually to go to work rather than to stay home. We pushed really hard very early to address some of these societal inequities in order to protect the health of individuals, but also protect the wider public health.
Thank you. That's great. Zaid, are you there? I'm just wondering if you would like to ask your question or give us a bit of more background to it. The question is, how have you handled business resilience plans for issues like power outages or natural disasters, considering the reliance of technology on electricity? So what's your business continuity kind of plans? And I guess asking that because it feels like you've been doing it for longer and you're further ahead than us. So how do you manage it?
So business continuity actually is, again, one of the fundamental principles, ensuring that we didn't get to the end of the pandemic and discover that we had lost a large percentage of our general practices because they become bankrupt due to the economic disruption of the pandemic. And the Australian government provided additional incentive payments to keep general practices open and to allow general practices to continue to employ their practice nurses. So that was really, really important. I've read alarming reports from the United States of up to 15% of family practices in some states having gone bankrupt and closed their doors during the pandemic. And that means, we'll come out of the pandemic and lots of the infrastructure of the primary healthcare system just won't exist anymore in some parts of the world. The challenges of the environmental impact are things that we deal with all the time. You're quite right, Anne-Marie. We're dealing with it at the moment with the floods in New South Wales and southern Queensland. We've had 37 of our general practices rolling out the vaccine, which have not been able to receive deliveries of vaccine or have had to close and are not able to deliver the vaccine. Obviously, we just pause the system. Fortunately, for those practices, even if the GPs and the nurses can't get to work, they can still use telehealth to provide consultations to their patients. Patients can still make bookings, prescriptions can still be written and transferred to pharmacies. So things that we couldn't have done a year ago during a natural disaster, we're able to do now. It's pretty amazing. The other thing I wanted to say was that we're not resting on our laurels. We're very conscious that once the borders open between Australia and the rest of the world, we will have community transmission of COVID-19. And we will, if we haven't already had a third wave, we will likely have a third wave of COVID-19. What we hope is the majority of vulnerable people will have been immunised and immunised effectively by that time, and we won't get our healthcare system overwhelmed. So we still have rocky days likely ahead. And I remember I was at Oxford in early February last year, meeting with Trish Greenhoe and with Richard Hobbs, and Richard said, "Oh, you think you're very smart in Australia, you just close your borders, you keep it out, but eventually you're going to have to open your borders again, and then you will have this naive population which has not developed antibodies." Well, we're not quite sure whether having been infected actually is going to protect us for very long. in the future. I think that what we're learning about COVID-19 is the more we know, the less we know, and things that we feel very certain about, many of those are going to prove to be not so as we move through into the future.
That's super. That feels like a very nice. I know that we've only got a few minutes left, and I'm sure you've got something else to be going on to. Otherwise, we could definitely keep going with questions that are sort of coming up here. I wonder if we could share some of those answered those questions with you maybe afterwards, and if you've got any kind of little responses, we'll circulate those out as well, because I'm sure you have to get on now. And I mean, there's a question there come up about being able to synthesize data and use it, and that's something I'd really love to know about how you manage that, because lots of I don't know if you did something like the shielded patient, that kind of concept, the shielded patient list, trying to identify most high-risk people. And also you mentioned there about prioritizing people for vaccination and using data in a way to do that. I find just that we have had many more eyes on data at the moment, and much more so you start spotting all the anomalies whenever you start moving data from the one purpose that it was recorded for, put it to another, and brings up, I think, lots of questions about how you will do big data with in a way GP or primary care data in the future without actually getting quality better. One of my personal feelings is the way to do that is probably to get patients having access to the records, so that we don't have people having epilepsy recording the records that don't really have epilepsy, but maybe, you know, thought it maybe one time they did. And I think those are going to be our big sort of challenges to kind of come forwards. But this has been an exceptional like tour de force, and you know, because of all your roles and what you've been involved in and how you're doing it, and still very live in it. It's been a real privilege to get to hear from you tonight, Michael, or tomorrow morning as it is. And so I'd just like to thank you so much for coming and giving us your time, and to everybody that's came in and participated and listened in and asked some questions. Just really grateful, and it feels like something that we'll be coming back to again, wasn't it? We're not still through the woods. We could come back to this in another 6 months or a year's time and have a different conversation about it. So thank you very much.
Thanks, Anne-Marie, and thank you, colleagues. It's a real privilege to be able to meet with you today, and thank you for all the great work that you're all doing in your local communities.
Super. Thank you.